Dear colleagues, ladies and gentlemen, it's a great pleasure to introduce Samuela Di Natale. She is a fourth-year resident and started her surgical education in the Hospital of Baden and joined our team about 1 year ago. She will be talking about the current concepts of anal cancer, and the floor is yours. Thank you very much.
Good morning and welcome everyone. As mentioned before, today I'm going to talk about anal carcinoma. I would like to thank Dr. Helena Garcia-Schüler, who can be here today, for her collaboration and for providing of some images. I will start with a short introduction, followed by some epidemiological data, risk factors and symptoms, pre-treatment workup and treatment, and last but not least, follow-up after anal carcinomas and take-home messages. The WHO classification divides anal cancers into two categories: tumors of the anal canal and tumors of the anal margin. As shown, different tumor entities can develop in both in the anal canal and the anal margin. Today, I will only talk about squamous cell carcinoma, which accounts for about 85% of all malignant anal cancers. In clinical practice, the term anal carcinoma is used equivalently for squamous cell carcinoma of the anal canal and anal margin. In order to better understand the difference between the tumors of the anal canal and anal margin, as well as the pathway of lymph node metastasis, I would like to shortly repeat some anatomical characteristics. The anal canal has a length between 3 to 4.5 centimeters, depending on size and gender. The dentate line divides the anal canal into an upper and lower zone, which have different origins of arterial supply, nerve innervation, lymphatic and venous drainage, and epithelial lining. The anal margin is defined as skin tissue with a radius of 5 centimeters from the anal verge, consisting of keratinizing squamous epithelial tissue containing hair follicles. So as I mentioned before, there's a different lymphatic drainage in the upper and lower zone, which determines the pathway of lymph node metastasis. In the upper zone, the lymphatic drainage goes to the perirectal lymph nodes and along the internal iliac artery, and in the lower zone to the inguinal lymph nodes and external iliac lymph nodes. Anal cancers accounts for about 1 to 2% of all gastrointestinal carcinomas. According to the Global Cancer Observatory, the incidence in 2018 was 0.53 per 100,000 people worldwide and 1.4 per 100,000 people in Western Europe. The reported mortality in 2018 was 0.2 per 100,000 people worldwide and 0.25 per 100,000 people in Western Europe. Most patients were diagnosed at the age between 58 and 64. As shown in the image on the right, there's a female predominance. In Western Europe, the ratio is almost 1 to 2. In the past 30 years, an increase in incidence has been observed. Now, according to population-based case control studies, different risk factors for anal carcinomas have been observed. Can you tell me one of the risk factors for anal carcinoma?
Maybe men having sex with men?
Yes, that's right. So, lifetime number of sexual partners, receptive anal intercourse, men having sex with men, HPV and HIV infection, as Massimo told, history of sexually transmitted disease, history of cervical, vulvar or vaginal cancer, immunosuppression after solid organ transplantation, and cigarette smoking have been found to be risk factors for anal carcinomas. The relative risks of the 3 most important risk factors have been reported to be 50 in men having sex with men, 33 in patients with HPV infection, and between 15 and 35 in patients with HIV infection. Due to a recent lecture about HPV infection and HPV-related lesions, I will only summarize the most important relations between HPV infection and anal carcinoma. Up to 93% of anal carcinomas are associated with a HPV infection, most commonly with HPV 16. A persistent infection with a high-risk form of HPV is associated with a higher incidence of anal carcinoma. High-grade anal squamous intraepithelial lesions are considered to be possible precursors of anal carcinomas, and the progression of high-grade squamous intraepithelial lesions to invasive carcinomas is related with HIV seropositivity, a low CD4 count, a high-risk HPV infection, and higher level of DNA of high-risk HPV types in the anal canal. Now looking at the symptoms, early symptoms of anal carcinoma are rectal bleeding, sensation of a rectal mass, and pruritus. 20% of patients present with no tumor-related symptoms. Patients with an advanced anal carcinoma may report about anorectal pain or rarely about incontinence or obstructive symptoms. The pre-treatment workup consists of physical examination, including inspection of the anal canal and digital rectal exam, endoscopy, palpation of the groin, and gynecologic examination for women. A colonoscopy can be performed optionally. So a biopsy of suspicious lesions should always be performed. CT scan of the chest and abdomen and/or an MRI of the abdomen and pelvis and/or a PET-CT scan has to be performed for better assessment of the local regional spread and to rule out distant metastasis. Patients should also be tested for an elevated CEA and SCC antigen, and patients with an unknown HIV status, an HIV screening test should be performed. Now looking at the T&M staging of anal carcinoma, in difference to other tumors, the T stage depends exclusively on the tumor diameter. And due to the different lymphatic drainage, depending on the position of the tumor, there's only a N1 stage. In this table, the classification into 4 stages depending on the T&M stage is represented. Almost 50% of the patients present with a localized disease corresponding to a stage 1 or 2, or if locally advanced, a stage 3 disease, 29% with regional lymph node metastasis, corresponding to a stage 3, and 12% with distant metastasis corresponding to a stage 4 disease. In the past, non-metastatic anal carcinoma was treated with abdominoperineal resection. In these patients, a high recurrence rate and a 5-year survival rate between 40 and 70% was observed. Of course, every patient had a permanent colostomy. Now looking at the current NCCN treatment guidelines for anal carcinoma, the main difference between the treatment of carcinomas of the anal margin and anal canal is that T1 and 0 carcinomas of the anal margin can be treated with a local excision. In these images, you see a T1 and 0 carcinoma of the anal margin, which was locally accessed with the safety margin, which should be at least 1 centimeter. Local excision should never compromise sphincter muscles. T2 to T4 carcinomas of the anal margin with or without lymph node metastasis, and T1 to T4 carcinomas of the anal canal with or without lymph node metastasis are treated with combined radiochemotherapy. In 1974, Niger et al. Performed a study on preoperative 5-fluorouracil and mitomycin concurrent chemotherapy and radiation in patients with an anal carcinoma. Surprisingly, they found a complete tumor regression in the first 3 patients. The therapy management changed subsequently from abdominoperineal resection to a combined radiochemotherapy. Now looking at our regime in our hospital, the preferred chemotherapy regime is cabazitaxime and mitomycin. In patients with contraindications for cabazitaxime, 5-fluorouracil is used instead of cabazitaxime. Mitomycin is applied on day 1 and rarely on day 29. Cabazitaxime has to be taken twice per day by the patient on days radiotherapy is performed. The radiotherapy is performed over a period of 5 weeks. The applied dose depends on the tumor stage and nodal involvement. The total dose ranges between 36 and 54 gray for the lymph node stations and between 50.4 to 59.4 grays for the primary tumor. On this slide, you see two treatment planning 3D CT scans. On the left, you see treatment planning CT scan, which included the primary tumor as well as the inguinal and iliac lymph nodes. On the right side, a boost to the primary tumor was applied. Now, the side effects of radiotherapy are divided into acute and late toxicity. Acute toxicity includes radiodermatitis, which is seen in every patient. Cystitis and vaginitis are also seen quite often during radiotherapy. Late toxicity includes anal ulcers and stenosis, so patients with locally advanced stage should receive a prophylactic stoma prior to radiotherapy, or prophylactic stoma should be considered. A few patients also suffer from chronic proctitis as well as incontinence for diarrhea, dysuria and a contracted bladder, and women from vaginal dryness and stenosis. During radiotherapy, all female patients are instructed to use a vaginal dryness to prevent stenosis. The side effects of the chemoradiotherapy includes especially bone marrow toxicity and mucositis. In this table, you see the 5-year survival and local failure rate with 5-fluorouracil, mitomycin, and radiotherapy. Interestingly, a local advanced stage has a higher impact on the 5-year survival rate and local failure rate than a nodal involvement. In the past, many studies which investigated different treatment regimes has been conducted. In patients which were managed with the radiotherapy alone, a complete remission was seen in 54%. The colostomy-free survival was 32% lower and the death rate 14% higher compared to patients which were treated with radiotherapy, 5-fluorouracil, and mitomycin. They also had a 13% higher relapse rate at 5 years. Now, in 2014, a retrospective study who compared 5-fluorouracil and mitomycin and radiotherapy to radiotherapy and cabazitaban and mitomycin was published in the British Journal of Cancer. 5-fluorouracil compared to cabazitaban, or better, cabazitaban compared with 5-fluorouracil showed no inferiority. The complete remission, colostomy-free survival, and overall survival rates were comparable. A complete remission was seen in about 90% at week 26. The colostomy-free survival ranged between 65 and 80% at 3 years, and the overall survival about 18% at 3 years. Now I would like to show you some pictures of a patient with a locally advanced carcinoma of the anal canal. As you may see on the CT scan on the left, there's a quite big lesion in the anal canal, which was about 5 to 6 to 8 centimeters. This lesion looked like the image on the right during endoscopy. Due to the locally advanced stage, this patient received a prophylactic stoma prior to radiochemotherapy. During the radiochemotherapy, he developed a wound due to tumor necrosis as well as a radiodermatitis. After completed radiochemotherapy, the wound as well as the radiodermatitis healed completely. So the third picture was taken about 2 months after completed radiochemotherapy, and the fourth picture about 6 months after completed radiochemotherapy. And this CT scan was taken 8 weeks after completed radiochemotherapy, and you see that there's only a small lesion left. Now, after the completed radiochemotherapy, an evaluation after 8 to 12 weeks with physical exam and digital rectal exam has to be done. If a complete remission is seen, the patient can or has to be surveilled regularly. The surveillance in our hospital is represented in this slide. It includes regular physical local exam, palpation of lymph nodes in the inguinal zone, determination of CEA and SCC antigen if elevated at diagnosis, and CT scan of the chest, abdomen, and pelvis. An MRI of the pelvis and an endoanal ultrasound should only be performed in clinical unclear findings. If a persistent disease is seen 8 to 12 weeks after completed radiochemotherapy, the patient can be observed and has to be reevaluated at 3 months intervals. If there's still a persistent disease 6 months after completed radiochemotherapy, an abdominal perineal resection has to be performed. The local regional failure rate after combined radiochemotherapy ranges between 10 to 30%. So the abdominal perineal resection is only a surgical salvage therapy. Unfortunately, the 5-year survival rate is quite low and ranges between 39 and 66%. Worst prognosis is seen with initial node-positive disease and the radiotherapy dose under 55 grays on the primary tumor. In a retrospective study, which included 105 patients which underwent an APR for persistent or recurrent disease, an overall recurrence was seen in 43%. T3 to 4 tumors and involved margins were more likely to experience recurrence. In this study, the 5-year survival rate was 60 to 64%. Now, if a progressive disease is seen 8 to 12 weeks after completed radiochemotherapy, a restaging has to be done to rule out distant metastasis. If there are no distant metastases, the patient should be scheduled for an abdominal perineal resection. All metastatic anal carcinomas are treated with a systemic therapy. And if there's a recurrence confirmed with biopsy during surveillance without distant metastasis, the patient should also receive an abdominal perineal resection. So last but not least, the take-home messages. You should know the difference between the tumors of anal canal and anal margin. You should remember men having sex with men, HPV and HIV infection as important risk factors for anal carcinoma. The treatment for non-metastatic anal carcinoma is a combined radiochemotherapy, and abdominal perineal resection is a salvage therapy. Thank you for your attention.
Ella, thank you very much for this very nice overview. Are there any questions from the audience?
Yes, Samuela, thank you very much. Very nicely, didactically presented. Congratulations, very good. When I see this, maybe the question is rather for Andrea. So when I see this disease, we have not so many in Switzerland per year. So how many do we have? And I see this is a complex disease, interdisciplinary treatments, and you patient really want to have access to the best choices because, I mean, there are a lot of side effects. We can see this radiation therapy, so quality of life is probably very often miserable after that. So my question is, how many cases we have in Switzerland? We know, can we speculate on that? And how are these patients treated? They are not in the whole specialized medicine, so it's not automatically centralized. So how they should be treated, and what would you advise that this patient may receive the best treatment?
Yeah, that's a very important question, and thank you very much for highlighting this. So it's absolutely a very specialized treatment, especially the radiotherapy. It has a lot of changes in the past. It's a highly individualized treatment, depending on the tumor size, the tumor location, the presence of lymph node metastasis, and the location of lymph nodes metastasis. The dose and the treatment is adapted. So there is no centralization of these tumors. So any hospital with a radiotherapy can treat those patients. I'm not sure about the total number of patients in Switzerland. Do you know any numbers, Matthias?
I don't have the precise figures on the numbers, but I can answer the second question very clearly. The disease is not centralized, which in my opinion is not a good idea, simply because, as we've nicely seen in your beautiful presentation, there is a high number of relapses after chemoradiation. And those relapses need to be treated by APR. And this APR in an advanced, very low-lying tumor is as complex as low rectal cancer, which is centralized by HSM. So this one is not. In my opinion, it's a mistake, and the numbers are low, so it would be a simple political task to centralize that disease. I have two brief comments to make. Again, beautiful presentations, and you've highlighted that nicely. One thing is the determination of complete remission. That has to be done at 6 months, and you've shown the graph where we already start doing examinations at 3 months, but at 6 months is where we determine complete remission or not. We see a number of patients with partial remission at 3 months, and it's important to not directly go for abdominoperineal resection at 3 months, because many of these patients will ultimately develop complete remission at 6 months. The second thing is the bad outcome after salvage abdominoperineal resection. That is our experience as well, and the problems that we have seen in multiple patients are that these patients develop early lymphatic recurrence, especially aortic nodal disease, and that is rapidly progressive. It leads to rapid systemic disease progression and ultimately to early mortality in these patients. So when they're not under control locally, they very quickly develop rapidly progressive systemic disease. Again, very nice presentation.
Great, good.
Other questions? Then thank you very much for your talk.
Thank you.